Hello. Good evening, sir.
Good evening, good evening. How are you?
I'm fine, sir. What about you?
I'm fine, I'm fine.
So
Sab
now,
ready, all well?
yes, sir. Sir, shall we start now?
Yes, I think Piali ma'am is come. I can't see Piali ma'am. Piali madam is here.
Ma'am is here.
And the other two speakers are also here. Yeah.
Yeah.
Anybody else is supposed to join or because we have just a few people?
Okay, sir. We will wait for 1-2 minutes more.
Yes, we'll wait for one.
Sure, sure, sure.
Rama ma'am, I think we can start maybe.
Sure, sir. Good evening, sir. Good evening, director, sir.
Good evening, sir.
Good evening.
Good evening, sir.
Hi, good evening.
So, shall we start now, sir?
Absolutely, I am ready.
Okay, okay, sir. Okay, sir. So, good evening, everyone. With warm greetings on behalf of SGPGI, Unicef, and UP Dietetics Fraternity Group and Poshan Abhiyan. I welcome you all who have joined this webinar on nutrition and holistic care of newborn. I hope everyone is at finest of your health during this pandemic. As you all know that we are celebrating Newborn Care Week from 15th November to 21st November every year for for creating awareness of how to care newborn babies amongst general public. The theme of this year Newborn Care Week is week by Government of India is ensuring quality, equity, dignity for newborn care at every health facility and everywhere. Newborn baby is a miracle of life and cutest little bundle of joy. There is a famous line that with every newborn baby, a little sun rises. But 24 into 7, that means once you sign on to be a mother, that's the only shift they offer you. In this webinar, all lectures will focus on different aspects of newborn care, and I hope that everyone will enjoy and learn from every lines of the lecture. Now I'm going to invite our dynamic organizing chairperson, Pyali ma'am, for the welcome address. So over to Pyali ma'am. Thank you.
Thank you so much, Rama. It's a pleasure and an honor to have all such members, such great people out here. And I must welcome our director, Dr. R.K. Dhiman, to this holistic care approach to the newborn webinar. And I will also, my co-participants, Dr. Richa Pandey and Dr. Mainak are already here. I welcome these people also to the webinar. My best wishes also. I will invite Dr. Moinak to introduce everyone out here.
So thank you, Piali ma'am, for that warm welcome, and good evening, Professor Dhiman, for gracing this occasion. Uh, I welcome Ms. Rama Tripathi, Dr. Richa Pandey, and also Dr. Shilpa Verma for this meeting. Today's meeting is nutrition of the holistic care of the newborn. And as you see the today's agenda, this is a combination of three questions basically. What the mother has had during pregnancy, how that has affected the newborn, and how that newborn has fared over the next 1000 days. So on these three parts of the agenda, three renowned speakers will be speaking. Now I invite Professor Dhiman, sir, to give us, our director, Professor Dhiman, to give us some pearls of wisdom, sir. Thank you.
Thank you so much. First of all, I am grateful to Dr. Piali Bhattacharya for inviting me to this symposium. And also, I come to know that there are the three distinguished speakers. Dr. Piali Bhattacharya, who's the senior pediatrician from Sanjay Gandhi, and Dr. Richa Pandey, nutrition specialist, Unicef, Lucknow, and Dr. Shilpa Verma, honorary national secretary, IAPN, Moinek, Rama Tripathi, who's the senior dietitian, and the Mridul Vibha. First of all, I would say that I am not an authority as far as the pediatrics is concerned, and particularly nutrition in the newborn. But I know one thing, that every woman deserves a healthy pregnancy, and every child deserves a healthy start. Not only the deserves, I will go to the extent that is the right. That every woman has a right to have a healthy pregnancy, and every child has a right to a healthy start also. And no matter where they live, whether in India, abroad, or anywhere. And I have come to know for the first time that this newborn care week is observed every year in the month of the November, from the 15th to the 21st. And the aim is basically at creating awareness among people about the importance of the newborn care for eradicating neonatal deaths and the increase in the survival rate. I think that is very, very important. If you give your attentions to the first 28 days of a newborn, that you call it the neonatal period, I think it is a very crucial period. It is basically, I would say, the foundation stone for the future health of the baby. A healthy newborn, healthy baby child develops into the healthy adult, and that would be a very, very important for any nation or any society or everywhere. But this period carries the highest risk of the deaths per day than any other period during the childhood. So much so that the 1/3 of the deaths that I have come to know, that occurs even on the first day, and the 3/4 of the deaths within 1 week or so. So it is astonishing, I would say. So something has to be done for this thing, and I am sure that at every level, starting from local societies to the national level, there are the few programs I have come to know also, and ultimately they are aimed to reduce the neonatal death. Coming to the infant mortality rate, what I have been told is it is in the 2018, it was 32 deaths per 1,000 live births, and it is lesser by 4 point. Just a minute. I have to close it. Sorry for the interruption. And in 2019, it was 30.924. And it is a decline of 3.36% from the 2018. It is declining, but I don't know that is it an adequate or it should be faster. I think the persons who are speaking here, they can deliberate upon it also. And there are the three main reasons for the death during this time, neonatal time or newborn. One is the prematurity or the preterm, 1/3, and neonatal infections. That is very, very important. When we talk of the infection, we talk of the nutrition also. I think if a newborn or in a neonatal period or even later on, if the nutrition, proper nutrition is not given, so these children or neonates, they are high risk of getting the infection. And other way also, if you get the infection, then the nutrition would be poor. I think if somebody is concentrating on the nutrition as well as on infection, I think the major problem of this period could be solved. Once again, at the last, I would like to repeat that every woman deserves a healthy pregnancy and every child deserves a healthy start, no matter where they live. Eating a nutritious diet during the pregnancy is also very important because it is linked to good brain development of the child and a healthy birth weight and can reduce the risk of many birth defects also the mortality and so on and so forth. I don't know whether I think good nutrition during the pregnancy, it results in I think the birth of a healthy child. So a balanced diet will reduce the all risk they are related to this period also. Therefore, I would like to emphasize that women, not only in the pregnancy, but any adult woman should have a good nutritious diet, particularly during the pregnancy also, and because it is linked to the healthy newborn. I think I am not the expert, but this is something I could gather. Uh, as far as the pregnant woman is concerned, and the newborn is concerned, and the early childhood is concerned, everybody is aiming to reduce the different kinds of the statistics, you can say, infant mortality rate, neonatal mortality rate, and so on and so forth. And nothing could be more important than a nutrition during the pregnancy as well as in the early childhood of any child. With these words, I would stop here, and I thanks again with each and every member who is participating in this symposium or its seminar today. And thanks again for inviting me. Thanks a lot.
Thank you very much, sir. Those were very inspiring words and in fact very updated and important statistics for us. And with this background, sir, we would like to, with your permission, we would like to begin the agenda. Is that all right, sir? Can we start?
Yes, please go ahead.
So, sir, we have a slight change in the speaker schedule. Dr. Shilpa Verma has requested that her talk be preponed a little earlier. So, is Madam Verma around with us? Madam Verma? We can't hear you.
Yes, sir, I am around.
Okay, thank you, ma'am, and welcome to the this meeting today. Dr. Shilpa Verma, She will be presenting nutritional factors during the pregnancy and immune responses. Dr. Shilpa Verma is a consulting nutritionist at Mumbai, and she has a lot of certificates to her credit. She's also a chief program officer of the Indian Association of Parental and Enteral Nutrition. And she is also a society member of the British and the American nutrition societies. So with that, Madam Verma, please start off your presentation. Thank you.
Thank you. And sorry for the inconvenience that was caused because of the reshuffling. And thank you for accommodating me.
Thank you.
Good evening all. Honored and thank you for this opportunity, Dr. Dhiman sir, Dr. Piyali Bhattacharya ma'am, Dr. Mainak Singh, Rama Tripathi ma'am, Mridul Vibha ma'am. Privileged to be on this webinar. I will talk to you all today on the nutritional factors during pregnancy and the immune responses. So to just give you an overview, we will briefly discuss, So we will briefly discuss on the immune responses, but we know that this is a very broad topic to be covered in this talk by itself. But we will touch upon the immune responses during pregnancy, the positives for the same for a fruitful and safe pregnancy, and then this will also provide us an insight to the negatives of the immune responses for both women and fetus, and then focus on the nutrient factors that can aid the positive immune responses, with the background that balanced nutrition is one of the primaries that support this magical journey of pregnancy. So if we can see here the NFHS 2015-16 data, in India, we still have widespread malnutrition and thereby high prevalence of low birth weight infants and very high maternal mortality. So additional nutrients are required for the fetal development, growth of maternal tissues, and to support the fetal growth. So needs of growth, the brain development, and the nutrient, when we are considering or establishing nutrition during pregnancy, one needs to also be careful about priming the immunity. The ontogeny of the human immune system is sensitive to nutrition, rather even in the very early embryonic stage. So therefore, both a deficiency or excess of macro and micronutrients can then be potentially detrimental. The best time to provide this nutrition support thus is prior conception, and the Federation of Gynec and Obs to supports that preconception nutrition is the route to a healthy pregnancy. If we look at the current evidences and what was previously thought of, previously it was thought that the maternal immune system played the major role in the fetus and the microorganism, and the fetal responses were considered limited. And the old concept was also that pregnancy is associated with immune suppression. So this created a myth that pregnancy is a stage of immunological weakness rather, and hence susceptibility to infectious diseases. But now the new integrational model takes into consideration that the fetal placental immune response and the maternal immune response are both integrated, and rather the placenta is an immunoregulatory organ and aids to modify the immunologic response in mother to the organisms. Broadly classified, the immune responses are either acute phase, which where there is secretion of the acute phase proteins, or chronic phase. And there is a bilateral relationship between the immune system, microbiome, metabolism, infection, and nutrition is one of the primaries to this relationship. Pregnant women are considered a special population, because I think pregnancy represents one of the most important times for the conservation of species, and therefore it is important to strengthen and protect the mother and the offspring in by all means. So basically, there are two types of responses, the adaptive immunity and the innate immunity. The adaptive responses are cell-mediated responses, which are carried out by the T cells, and the humoral immune responses, which are controlled or activated by the B cells and the antibodies. So adaptive immunity may take days or weeks, and upon exposure to pathogen or antigen or vaccination, and without the information from the innate system, probably the adaptive responses are not mobilized. When we look at the cellular constituents during the first trimester, immune cells that accumulate in the human endometrium at the time of decidualization, they play a critical role in implantation or placental development. And of these, the most important are the phenotypically unique NK cells. These cells dramatically increase and they account for literally 70% of the population of the cells of the leukocytes during the first trimester. And then there are the macrophages and the T cells. The B cells are virtually little undetected. And the majority of the NK cells are the CD56 and the CD16. Now, during the 3 trimesters of pregnancy, there is a shift between balance from pro-inflammatory markers to the anti-inflammatory responses. So during the first stage, implantation, placentation, and the first and the early second trimester of pregnancy resembles like an open wound. And this will require a very strong inflammatory response. Whereas in the second phase, in many ways, it is an optimal time for the mother. And this is a period of rapid development and growth. And the final immunological phase, anti-inflammatory responses of M1 macrophages, Th2 are elevated, and NK cells and M1 macrophages are reduced. And now the fetal development has completed. The organs are functional, and this is a time to deliver the baby, which is achieved by renewed inflammation. Also, hormones play an important role in the immune responses. So changes in estrol, progesterone can lead to immunological shifts during pregnancy. Also, the hypothalamus pituitary axis is activated at times of low nutrient availability, especially protein energy malnutrition or zinc deficiencies, and increased cortisol levels can lead to immunosuppression and alter the placental functions, which will directly impact the fetal immune system. Hence, if we know the positives of the immune responses, we know the type of immune responses we are talking during pregnancy. If these responses are not matched for a healthy pregnancy, this then at times can lead to certain complications of pregnancy, such as eclampsia, preeclampsia, and in severe cases can lead to spontaneous abortions. So eventually, all these responses then are somewhere linked to the provision of nutrition. And we are not talking just micronutrients like the B group vitamins or vitamin D and A and C. We are talking of also of proteins, omega-3 fatty acids, probiotics. So all these need to be primed. And any of the deficiencies can then lead to malnutrition. And we don't want this effect of undernutrition, which can be a consequence of the maternal diet. And when the nutrient demands exceed the supply of fetal undernutrition, we are talking long-term consequences, and hence it is necessary to provide optimal nutrition. Maternal nutrition deficiencies can lead to stressed immune responses. So hormonal adaptation to epigenetic gene regulations where protein, folate, vitamin B12 play a role. All these nutrient factors are then important to maintain the renal function, to body composition, even the cardiovascular functions. So the effect of diet on the development of human immune system begins from the embryonic stage, or rather before it. So if we talk of the recommended dietary allowances for pregnancy, we can find these even on the net. What I would like to say is micronutrient deficiencies generally do not exist as singular deficiencies. They are often multiple and can have various causes, right from poor absorptive capacities during pregnancy to the availability of foodstuffs. If we look at the protein recommendation, 723 grams per day in the first, second, third trimester, when planning for a pregnant lady, it's important that we try to balance it within the meals that are given through the day. Something like just consuming one serving choice of protein source during each meal can somewhere help us reach those protein goals without too much supplementation. And we know that balanced protein supplementation can reduce the number of SGA infant borns by around a third. Moving on to iron requirements, if a patient is chronically anemic, the iron stores also stand to be depleted. And when prescribing iron, one needs to be mindful of the heme and the non-heme iron sources, where heme iron has better absorptions. The FOXI guidelines are also there for management of iron deficiency. And it says that universal screening of iron deficiency anemia with hemoglobin is recommended for pregnant women at the first antenatal visit. Zinc is another necessary micronutrient for infantile growth and development and neonatal immune system. Sources of zinc can be right from oysters to beef to blacktail to eggs to chicken to lentil, oil seeds. So all these various sources can be included into different parts of the meal to see that those requirements are met. So if we look at these case studies, it does show that optimal zinc and beta carotene levels are conducive to normal immune responses and then to fetal growth. Moving on to the EPA DHA. DHA builds healthy tissues and many organs throughout the fetal development, and it improves pregnancy, birth outcomes, and infant outcomes. DHA is generally found in fatty fish like the salmon or sardines or mackerel. In vegetarians and vegans, especially, the sources are limited to seaweed and algae. In vegans, we can also say that the human body will use the ALA from vegetable oil and nuts like walnut and flax seeds and convert it to the biologically active EPA DHA, though the conversion may not be so efficient, and then probably one needs to think about supplementations. Vitamin D is one of the most, I think, researched vitamins in pregnancy, diabetes, etc. And it contributes to diverse immune responses, including the promotion of Th2 and the regulatory T cell signaling, and also enhances the functions of the monocytes and the macrophages. Iodine deficiency, it poses another risk to infertility, increased abortions, first trimester abortion. Prevention can be use of iodized salts or as per the supplementation as per the FOXI guidelines. Vitamin A, it's one of the most important vitamin to maintain the integrity of the mucosal surfaces. And we know that the deficient state is associated with increased risk of infections in the respiratory, the GIT, or even the ocular infections. And the deficiency of vitamin A can interfere with the phagocytic or the NK cell function. So different vitamins and different macro and micronutrients play a role in building up the maternal immunity and also the fetal immunity. If we look at vitamin C, important for connective tissue growth and protects the mother and fetus from oxidative stress. Lack of folate or deficiency of folate can impair the immune system and lead to neural tubal defects. So if we look at the studies, various studies from Medline, Scopus, Popline, they all show that micronutrients aid the maternal immune health and subsequently the fetal growth with less chances of infection in the fetus and the infant too. Moving on, pregnancy is also a period of the developmental window for early gut microbiota and the neurodevelopmental trajectory, which has outcomes later also in life. So inappropriate dietary shifts from natural foods that we have been eating to processed foods, high fat, high simple carbohydrate, low fiber diets can cause these shifts in the intestinal microbiota. And these effects then are observed in some areas of immune system and may cause changes in the gut mucosal immunity, which is the first point entry of the dietary components. And it can also influence the microbiota of the infant before birth. So these microflora have evolved to have a symbiotic relationship. So what I am trying to say here is when the nutrient intake influences the composition of the gut microbiota, this in turn will influence the availability of the nutrient for the absorption from food. And if this is not right, we are talking about leading to malnutrition. And this impact can lead to the vicious cycle of malnutrition, where healthy gut flora will help to promote the mucosal tolerance to non-pathogenic antigens and enhance the absorption of nutrients and prevent malnutrition. So if we look at the refraction curve here, it shows a difference in the divergence of the gut microbiota of healthy and malnourished child, where it can be even protective for stunting. So if the fetus develops sufficiently, we have normal weight, we have normal size, which is an important criterion for the health of the fetus and the infant. Analysis of this linear discriminant algorithm also shows that stunted have inflammogenic pathogens, whereas the non-stunted infants would have enriched probiotic protective species. Important is also the total dietary fiber. It is composed of several subcomponents like the soluble fiber, the insoluble fiber, and then we have the prebiotics, and we also have the probiotics and the resistant starch. So the composition of the gut microbiome is largely related to the dietary fiber intake also. Dietary fiber are fermented to certain bacteria, which result in the production of short-chain fatty acids, and like the propionate, the butyrate, and the acetate. These short-chain fatty acids are known to have an immunomodulatory effect in the gut, and thereby they may have a protective role or a potential role to play in the regulation of the T cells of the gut. So exposure to microbes in early life, which was through microbial colonization in the newborn intestine, or even through the traditional dietary pattern of fruits, fish, vegetables, specific nutrients, they are associated with reduced risk of allergic diseases in the offspring. Thereby, we may say that dietary modulation of gut microbial composition might be a novel approach, and more research needs to be put into this for a very positive outcome. If we look at the evidence-based meta-analysis, it shows that maternal composition of probiotics or symbiotics can lead to measurable change in the composition of the offspring's microbiome. And thus we can say that the neonate's gut is strongly influenced by the maternal microbiome, and probably by altering the nutrient status of the mother, we can even influence the immune functions in the child. The mother's nutrition status may affect the neonatal immune system by even the epigenetic modifications. And the epigenetic modifications are by the DNA methylation or the histone modification or the non-RNA codings. And alteration in the DNA methylation is a key metabolic function for gene regulation, which is induced in the famine times, exposure during early life, and can have it persist for 6 decades. And these modifications may be altered in response to environmental factors, and in some cases it can be heritable. So maternal nutrition, maternal immunity, fetal neonatal nutrition, and neonatal immunity are thus an interlink bit of what starts at the times of maternal or preconception nutrition. The dual teratogenesis of undernourished mother can lead to undernutrition, and altered fuels can lead to overnutrition, and we are talking of nutrient mediated or fuel mediated teratogenesis. So to conclude, the optimal nutrition interventions improve immune responses in mother and the fetal health. So preconception nutrition is primary. Pregnancy may bring forth many physiological changes in the normal course, like morning sickness, constipation, heartburn, cravings. At times, there are pre-existing illnesses also. So all these need to be considered when we are individualizing nutrition based on evidences and practicality, and also take into consideration the socioeconomic status and aim for a healthy pregnancy. So to conclude, the main nutrients would be calcium, the proteins, the dietary fiber, the DHA, the probiotics, and the immunonutrients of iron, folic acid, and B12. And this has to start preconception to prevent the cyclical story of maternal and fetal malnutrition and to enhance the outcomes of the pregnancy. Thank you very much.
Thank you, Ms. Shilpa Verma.
Thank
I
you.
think if you have time, would you be taking the questions right now, or can you stay till the end of the?
I will stay. I will come back at 6.
Sure. So I think we can take all the questions at the end, because these topics are all interlinked. So our next speaker is Dr. Piyali Bhattacharya, who will be speaking on the best practices in feeding in the first 1,000 days. Dr. Piyali Bhattacharya is our pediatrician here at Sanjay Gandhi Postgraduate Institute of Medical Sciences, and she's been here since 1990. Once there's a lot of noise in the background, I would request those who are not speaking to kindly mute. So as I was saying, Dr. Piyali is our senior pediatrician here at Sanjay Gandhi Institute of Medical Sciences, Lucknow. And she has been the president of the Uttar Pradesh Indian Association of Pediatrics. She is also has been given a lot of prestigious fellowships from the IAP. She's also received a fellowship from the Royal College of Physicians in London. And she specializes in newborn care, and she's a brand ambassador for adolescent healthcare from IEP. She's a keen researcher with a lot of national and international forums. And personally, she's my favorite pediatrician because she takes care of my children as well. Thank you, madam. Over to you.
Thank you so much. So, best practices in feeding in the first 1,000 days. A very important thing to understand and absorb for everyone, because what we are of the species called Homo sapiens, Homo sapiens literally translated would mean wise man. So are we all wise regarding the best practices in feeding our young ones, or do we need to know or revise what we already know? So the first 1,000 days refer to the period from the moment of conception. Any nutrition of a child or any care or the holistic care, as we say, starts from the womb. The mother conceives at that point of time and continues till the second birthday is achieved. So it's the first 1,000 days which refer to the period of conception to the child aged 24 months. Why are they so important? When we say first 1,000 days, we need to understand that the first 1,000 days are a period of rapid growth. During pregnancy, those 9 to 10 months, rapid growth, absolutely, from a single cell, to a whole human baby. Then again, the period of breastfeeding is very important. It is a period of rapid growth. The child needs nutrition. And then comes weaning, when we switch over to solid food and the toddler's food. So in summing up, it is important because what you do, what you eat or experience during the first 1000 days has a lifelong consequence on your health. When the child is little, there are so many miracles happening in the child's body all the time. So when we talk about miracles or significant developments, we need to understand that the child's brain is maturing, the cognitive development is occurring. Simultaneously, he is growing brain and brawn, and simultaneously, there is an immune maturation occurring. The metabolic organs are actually maturing, and the digestive system, about which Dr. Shilpa was speaking, is maturing as well. So what happens to the physical growth? One cell at conception gives rise to 500 trillion cells by 3 years of age. Triples the birth weight in the first 1 year and growth more in the first 3 years than in all life taken together. Cognitive development, as I said, why is it so important? Every mother wants her child to be first in the class, get 99.99%. But remember, for that, you have to understand the significance of the first 1000 days of life. 80% of adult brain mass is achieved by 3 years. And in the first 3 years, there's a 3-time increase in the weight of the brain. Not only that, you will be surprised to know that the child learns about 900 words by the time he is 3 years old. Talking about the immune maturation, it takes about 2 years to develop the body's most potent immune organism, the gut barrier. So the gut has around 1 kilo of microorganisms in it, and they crosstalk with the gut, and there is something which is referred to as the brain-gut axis. So important again, the maturation of the gut barrier. Early life colonization is crucial, and that depends on the mode of delivery, on the nutrition, whether the child is breastfed, whether the child is given complementary feeding on time, whether the child is given cow's milk, whether the child has been delivered by LSCS or whether the child has a normal delivery. All these will in fact affect the immune maturation. Digestive system, again, as you all know, that the child is born with an immature gut, and the digestive and the absorptive capacity gradually develops in the early years. हम लोग पहले माँ के दूध से शुरू करते हैं और gradually हम लोग उसको wean करके complementary diet पे लाते हैं. So the immature gut gradually matures and learns to accept the food that the Homo sapiens take. ये वाला हिस्सा जो हमने रेड मार्किंग में किया हुआ है, ये इंपॉर्टेंट एरिया है, where from the period of conception to 2 years of age, you can see the yellow line, how rapidly the child grows, and thereafter there's a plateau, and finally, again, as the child matures to 2 years plus, it gradually starts decreasing the rate, and again it goes. When the child is a teenager, again there's a rapid spurt of growth. So these are the 2 periods when the child actually needs a lot of nutrition support, once in the newborn period and once in the teenage period. The impact is very, very critical. You will have to understand that if the child has, in the initial months of conception and at birth, till the weaning, if the child has optimal feeding, the child will have optimal growth and develop into a healthy adult. However, if there is alteration or if there is deprivation, the child will grow into a diseased adult. So the end, we हम बोलते हैं हमारे माँ बाप ने दिया, हमारे माँ बाप ने दिया. I've shown here, ये जो yellow portion है, just 20% of what we have is genetic, and rest of it, pura 80% of disease risk in the life is due to the environment, due to the nutrition, due to the lifestyle. So 20% खाली होता है इनहेरिटेड जीन्स जो हमें डिजीज दे सकते हैं, बट रेस्ट ऑफ इट इज इन आवर हैंड्स. सो न्यूट्रिशन, लाइफस्टाइल, एनवायरनमेंट इज इन आवर हैंड्स. एक बीइंग इफेक्ट बोलते हैं हम लोग. सभी ने बीज को देखा होगा, मधुमक्खी को. सो व्हाट हैपेंस इज, यहाँ पे मैंने वर्कर बीज दिखाई हैं जिनको 3 दिन के लिए इनको अच्छी वाली जेली मिलती है, और यहाँ पे मैंने क्वीन बी को दिखाया है जिसको 3 दिन की जगह डबल द डेज, 6 दिन को इनको अच्छी वाली जेली मिलती है. सो व्हाट हैपेंस इज दैट वर्कर बीज हैव वर्कर लाइक बिहेवियर्स. 6 हफ्ते में ये लोग मर जाते हैं. और when the queen bee later on lives for around 4 years, is larger in size and the behavior is totally different. तो आप वर्कर बी का 3 दिन का खाना और क्वीन बी का 6 दिन का खाना इतना डिफरेंस ला देता है. सो इन द ह्यूमन बीइंग व्हेन वी सी दिस, वी कॉल इट अ बीइंग इफेक्ट. प्रेगनेंसी न्यूट्रिशन, आई थिंक डॉक्टर रिचा विल टॉक अबाउट दिस इन डिटेल, तो मैं बहुत ज्यादा नहीं बोलूंगी. न्यूट्रिशनल स्टेटस ऑफ ए वुमेन बिफोर प्रेगनेंसी इज इंपॉर्टेंट. क्यों? क्योंकि अगर वो माँ बनती है उससे पहले वो कमजोर होती है तो कंसेप्शन पे और कमजोर होगी, बर्थ पे कमजोर बच्चा पैदा करेगी, प्रीमेच्योर प्रीटर्म बच्चा पैदा करेगी. जैसे कि डॉक्टर धीमन वाज सेइंग दैट द मेजर कॉज इज प्रीटर्म एंड इन्फेक्शन इन आवर कंट्री. सो प्रीटर्म अगर बच्चा पैदा करेगी तो आज नहीं कल नहीं, it will have a genetic effect, epigenetic effect, and for ages to come हमारे generations कमजोर होते जाएंगे. So लड़की का, बेटी का न्यूट्रिशन, ensure that she has good nutrition. अगर मदर अंडरवेट है, अगर मदर ओवरवेट है, दोनों ही स्थिति में it will be a health risk for the child. So nutritional requirements कुछ कुछ चीजों की बढ़ जाती हैं प्रेगनेंसी में. टोटल फूड इनटेक जो है वो इतना नहीं बढ़ता. सो हम कहते हैं ना 2 का खाना खा रही है, नहीं. क्वालिटी ऑफ फूड मैटर्स मोर देन द क्वांटिटी ऑफ फूड. सो maternal nutrition and breastfeeding are interlinked because breastfeeding woman के requirements जब तक पूरे नहीं होंगे, milk secretion अच्छा नहीं होगा, she will have a lot of problems in feeding their children. And because a lot of vitamin levels in breast milk are linked to dietary intake in the mother, again, we need to be very, very careful about the mother's diet. So since I'm talking about best practices, the first best practice that I will emphasize upon is promote and support good maternal nutrition during pregnancy. Dr. Richa will enhance on this. So while you are talking about good maternal nutrition, you must remember that education on optimal nutrition for exclusive breastfeeding is important. तो सिर्फ वो खाना ही नहीं खाएगी, उसको उपयोगिताएं भी बतानी है, इसको impress upon करना है, educate करना है why it is important to have good nutrition for exclusive breastfeeding. Again, who does it? You and me. We are health providers, we are community workers, we are providing these education. And सिर्फ माँ को ही नहीं, remember education of the father, education of the family, और खासकर हमारी society में education of सासू माँ is very, very important to have good nutrition for a pregnant or a lactating mother. Breastfeeding is the best way to feed a child, and today we know कि पोषण में बेस्ट आहार क्या है? बेस्ट आहार है खाना बच्चे का, ब्रेस्ट फीडिंग इनिशियली इन द फर्स्ट 6 months. तो हमें एक्सक्लूसिव ब्रेस्ट फीडिंग करनी है और हमें और कोई भी चीज नहीं देनी है. कई लोग जन्म घुट्टी देते हैं, नो जन्म घुट्टी. कई लोग हनी देते हैं, नो हनी. सो ब्रेस्ट फीडिंग एक्सक्लूसिवली इज द फर्स्ट बेस्ट प्रैक्टिस. शॉर्ट टर्म बेनिफिट्स होते हैं, कुछ लॉन्ग टर्म बेनिफिट्स होते हैं. शॉर्ट टर्म बेनिफिट्स हैं ब्रेस्ट फीडिंग के, दैट इट प्रोटेक्ट्स अगेंस्ट एनी काइंड ऑफ इन्फेक्शन. इट इज द फर्स्ट वैक्सीन फॉर द चाइल्ड इन फैक्ट. लॉन्गर टर्म बेनिफिट्स में बहुत सारी चीजें हैं. ऐसे बच्चे जो एक्सक्लूसिवली ब्रेस्ट फीड करते हैं, it has been seen that it is associated with a lower incidence of obesity, a lower incidence of diabetes, and a lower incidence of blood pressure and cholesterol. Now, higher performance in intelligence tests. Yes, many studies have shown. Devin, will you close the door? So many of them have shown that in the intelligence, the IQ levels are about 5% greater in these children. ह्यूमन मिल्क में आप देखो ना, बड़ा यूनिक सा कॉम्पोजिशन होता है. कोलेस्ट्रम पहले आता है, उसके बाद ट्रांजिशनल मिल्क, मैच्योर मिल्क, प्रीटर्म मिल्क, फोर मिल्क एंड देन हाइंड मिल्क. Each of these types of milk have a unique type of a constitution. Then will you please close the door? The nutrition components भी आप देखिए, अगर आप देख रहे हैं इस पाई डायग्राम में, तो you will find that there are fats, prebiotics, proteins and lactose. सबसे ज्यादा lactose है, proteins है, prebiotics है and fats है. So एक major portion is actually beneficial bacteria as well. So this again depends on आपका कैसा वाला delivery है, कैसा वाला nutrition है. So again remember that very important is the mode of delivery, very important is the mode of nutrition. So colostrum again, एक चम्मच भी बच्चे को मिलता है तो it is adequate nutrition for the baby. Now the best practice is, कई माएं सोचती हैं कि हम ना पिलाएं तो हम बहुत अच्छे रहेंगे, slim रहेंगे. So motivate the mother even before birth to feed the child. आप उसको बार बार समझाएं what are the benefits for her, what are the benefits for the baby, and motivate the mother before the birth. बाद में करने से उतना effect नहीं मिलेगा. Select the right place for delivery. आजकल we are stressing upon institutional delivery. So the best practice is institutional delivery. Avoid unnecessary use of drugs and other things. कई माओं को मैंने देखा है वो कोक ही पिए जा रही हैं during the, मुझे अच्छा लगता है pregnancy के टाइम पे कि मैं कोक पीऊं, तो वो बोतल कोक पी रही हैं, but that is not very good for the baby. So avoid unnecessary toxic things and soon after initiate breastfeeding soon after delivery. 1 घंटे के अंदर बच्चा इस लायक हो जाता है कि वो ब्रेस्ट फीडिंग ले, तो बच्चे को माँ के छाती पर लिटा दे and let the child root for the breast and accept breastfeeding within 1 hour of birth. Go for colostrum and avoid any कि ननद आएगी, काला टीका लगाएगी, फिर वो शहद चखाएगी. Avoid any prelacteal feeds and maintain a good position for suckling in the baby. I will demonstrate and explain this later on. So recommend ये करते हैं हम कि आप बार बार ना पिला के, बेबी जब डिमांड फीडिंग करे, जब मांगे, तब बेबी को दूध दे और भरपूर दूध वो लेगा उस वक्त और उसके बाद वो रेस्ट करेगा. So as long as the baby wants, you feed the child. And बार निपल धोने की जरूरत नहीं है, बार सफाई करने की जरूरत नहीं है. अगर माँ नहीं पिलाएगी, माँ को caution करिए that there may be breast engorgement. So the best practice is that the baby should actually be taking demand feeding and with correct attachment and correct latching. So correct attachment, when I say, if you can see me over here, this is exactly how you should be holding the baby in a straight line with your hands supporting the baby turned towards the mother's chest, the abdomen of the baby at the epigastrium of the mother and touching the mother. So baby को उठाना है, आपको नहीं झुक जाना है baby की तरफ. So remember that the baby should be towards the mother, not straight. बच्चे की गर्दन नहीं घुमानी है, बच्चे को पूरा घुमाना है. करेक्ट लैच अगर नहीं होगा तो what will happen? मदर के निपल में सोरनेस होगी, मदर का निपल क्रैक करेगा, mother will not be able to feed the baby. So what are the signs of correct latch? The baby's mouth should be wide open. Nipple sucking nahi karni hai. You have to have the areola and the nipple inside the mouth of the baby. नीचे का areola पूरा, ऊपर का areola almost all. And उसके बाद baby की थोड़ी chin should be touching the breast of the mother. So remember, nose should be free, chin should be touching, the mouth should be open and the areola should be in the mouth. So if you are actually correct latching the child, then there will be no problem in feeding or giving the child breast milk. Kabhi kabhi problem aati hai. There are inverted nipples. So when I was an intern, what we used to do is that हम पहले से माँ को mentally तो prepare करते थे, but we used to respond by asking her, हाथ में थोड़ा सा घी ले लीजिए और रोल करिए, अगर बहुत फ्लैट है तो जब तक बेबी डिलीवर होगा इट विल बी प्रिपेयर्ड. उसके बाद हम लोगों ने शुरू किया सिरिंज को काट करके उल्टी तरफ उसका पिस्टन लगा देते थे और माँ को चोट न लगे इसलिए माँ के ब्रेस्ट में एक पिस्टन को लगा करके उससे वैक्यूम क्रिएट करते थे, ताकि धीरे 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 करते करते जब तक डिलीवरी हो तब तक माँ के इन्वर्टेड निपल्स करेक्ट हो जाए. Another correct practice is burping the child after feed. Each meal, the child needs to burp and take out the extra air that the child has had. कई माएं will complain, बच्चे को कोलिक होता है, बच्चा complain करता है, बच्चा बहुत रोता है. Remember always that if the child is not burped properly, then there is a प्रॉब्लम विद द चाइल्ड. धीरे धीरे कंधे पे आप सहला सकते हैं या आप बिठा के बच्चे को सहला सकते हैं, और अगर उससे भी नहीं होता है, द प्रैक्टिस वुड बी टू पुट द चाइल्ड ऑन हिज टमी. 5-7 मिनट में ही उसका एयर इरेक्टेशन हो जाएगा, और उसके बाद आप बेबी को यू कैन फ्लिप द चाइल्ड ओवर. Remember always that breast milk, if you are working mothers, you have a problem, the best practice still remains to give breast milk. तो तब आप क्या करिएगा? You can give expressed breast milk, and this breast milk, please remember, आप सोचते हो बाहर खराब हो जाएगा, but if it put in a deep freezer, 3 से 12 महीने तक ये मिल्क स्टोर हो सकता है. बाहर भी छोड़ देंगे तो भी expressed breast milk can remain at room temperature for about 6 hours. तो अगर आप expressed breast milk देना चाहते हैं तो वो भी कर सकते हैं. And if you have a lot of milk, I will advise you to give it to the milk bank. KGMU has already started a breast milk bank which helps all mothers who cannot give breast milk to their children. Weaning becomes very, very important at the correct time, at the correct space, in the correct amount. So 2 key reasons why we need to supplement and complement the breastfeeding is, आपने 6 महीने तक exclusive दिया, 6 महीने पे those who are Hindus will remember we have a Annaprashan ceremony. So our old wise men knew that we need to give the child some complementary feed at 6 months. Even in the Quran, it is written that the child must be given complementary feed at 6 months. So those wise people have told us the correct age of weaning. And remember, it is always done with kheer or chawal. So we all know that rice never causes any problem, but wheat may cause an allergy if the child is not acclimatized. So starting weaning is always with fruit and rice. So each food should be given to the child. सब मिला के गबड़ के मिक्सी करके नहीं देना है. You have to give each food one at a time so the child acquires new tastes. Those children who are introduced to solid food by 8 months of age, the child will develop a chewing reflex और तब वो अच्छे से खाएगा. मिक्सी करके देंगे, remember the child will not recognize textures, the child will not recognize the feel, the child will not develop a healthy eating habit. फिर आप 5 साल तक मिक्सी किया हुआ खाना ही देते रह जाओगे. ये feed habits, ये conversion to weaning is also linked to the cognitive development in the child. वो बच्चा जब उस फल को पकड़ता है तो उसका size, उसका spatial arrangement, उसका color, उसका feel, texture सब समझता है. So जो बच्चे को आप उसको नहीं feel करने दोगे, that child will become a fussy eater later on in life. So remember that I have shown here in the blue portion per kg body weight compared to adults. The child needs 5.5% more times more of iron, 4 times more of calcium, 3 times more of essential fatty acids. So basically the young people have specific and greater requirements. अब हम लोग करते क्या है कि काम खत्म करने के लिए 2 मिनट में मैगी दे देते हैं, ये सब दे देते हैं. सो रिमेंबर, नो जंक्स एट ऑल. If the toddlers do these days who are eating too much protein, they are at risk of obesity. They're taking too much salt and they are at risk of blood pressure by the age of 20. Too much saturated fatty acids, again heart disease later on, and too much sugars. Remember, सब बच्चों के आजकल dental caries हो रहे हैं, दांत खराब हो रहा है. Not enough vitamin D again you have a lot of rickets and problems with all these things. So nutritional status becomes very, very important. So the second best practice is infant and young child care के जो भी चीजें होती हैं, follow the guidelines and care practices. Breastfeeding at 1 hour, engagement of the fathers and the family. Weaning started at 6 months and continue breastfeeding till the age of 2 years. Again, as you support them, there are ancillary things which you must look at. Integration of this with the safe drinking water. आधे से ज़्यादा nutritional problems arise from unsafe hand washing, unsafe excreta disposal, unsafe food hygiene. So you must look after the wash practices also. And we have so many supplementation and fortification programs which you must also tell the baby and the mother about, tell the mother and the family about. Remember, another very good practice is keeping the baby warm. Temperature has to be maintained at all costs. And what have we really learned? We have learned this from the kangaroo. We call it the kangaroo mother care. अगर आप लोगों को, आई डोंट नो हाउ मेनी ऑफ यू नो, बट कंगारू का बच्चा कुछ इंचेस का पैदा होता है, premature पैदा होता है, and it spends around 3 months in the kangaroo's pouch and gradually goes to a big size kangaroo. So skin to skin care, maintaining the temperature again is a birthright of this child. And skin to skin container, जब आप temperature maintain करेंगे, the child will have so many ancillary benefits. He can root for his food mother के nipple पर. He can actually gaze at his mother and feel comfort and support. So at risk बच्चा भी होता है, he is mentally stress free because he is with the mother in a skin to skin touch. So this is another best practice that you can give. So health and nutrition do not stop at just the baby's initial care, but you need to make nutritional assessments. You need to counsel the mother even after the first 24 months. So each time that you meet the child on a vaccination spree, you talk to the child and the mother and you counsel, you assess the child, you talk to the mother and you tell her what is there more that she can do good for the child. You address her concerns, so that again helps. Half of the mothers come to us and say, मेरा बच्चा ठीक से दूध नहीं पीता है, बढ़ नहीं रहा है. So there again you have to check कि सच में या actually assess करने के बाद आपको लगता है नहीं, the health pattern is all right. So if the health pattern is all right, you need to counsel the mother, reassure the mother. So amongst the community things that we do, आज हम जो कर रहे हैं, we are actually spreading communication to all of you, and I hope that everybody will counsel and help the mothers. And the concluding thing that I need to say is that the first 1,000 days offer a unique window of opportunity. Do not miss it because it's a period of rapid growth, and therefore it is crucial to ensure that every mother and child have access to optimal nutrition in the first 1,000 days. Thank you so much.
Thank you very much, Piali Madam. That was very lucidly presented. And we will invite a lot of questions after the entire session is over, because as I have said, most of the questions will be interlinked. So my next speaker is Dr. Richa Pandey. And Dr. Richa Pandey is a consultant who has been working very closely. She's done her specialization in community medicine in KGMC, and she's a consultant who's working very closely with Unicef on maternal and child health and nutrition issues. Dr. Pandey is earlier she has worked on various projects, very decorated projects which have been associated with the Johns Hopkins University. And with that, I would like to invite Dr. Richa Pandey for Association of Maternal Nutrition with the Birth Outcome.
Thank you, Dr. Monik. Just a small correction. I started my journey as a consultant with UNICEF, and now I work as a staff for UNICEF. So thank you for the opportunity. And at the onset, I'd just like to say, I think those were very, very technical presentations. So I'll go back to what Professor Dhiman was saying at the start, so I'll go more into the numbers, and as you move, or as we move from the hospital to the, the bigger public health arena, how the problem unfolds and how does it really look so I think over a course of last 15 to 20 years, we are trying, I would say we are struggling to, make these simple issues like breastfeeding, complementary feeding, maternal nutrition relevant, so that some outcome may be achieved. So that's the background of my presentation, more from what is happening when we take the interventions to a program setting, and that too in terms of public health. So what governments are doing, or what the state government is doing. So with that background, I start my presentation, and the title is Maternal Nutrition and Birth Outcomes. And specifically why I would want to talk about is the struggle that we face, in day to day, because when we are talking about maternal nutrition, it's not an isolated thing. It's something that is very closely linked to the maternal health paradigm. And but I think over the last 5 to 6 years, because we have not been talking about maternal nutrition, so it has emerged as a separate area which needs to be focused, because somehow maternal health is not delivering the results that it should. Of course, we have achieved a lot of reduction in maternal mortality rates. So obviously, our institutional delivery strategy is paying off very well. We have brought about a lot of reduction in the infant mortality rates also over past several years. So those areas are working, but there are still a lot of areas which we need to emphasize, which we really need to work upon. So coming to the first part of my presentation, which talks about basically we need to understand the association between the maternal nutrition and the birth outcomes, or the mortality component, because I think what really strikes people is the number of kids who are dying. If those numbers are talked about, I think it might kind of make more impact or more sense in terms of running a program. So can we request people to please switch off their mics if it's possible?
Please switch off your mics, except for Dr. Richa. Everybody else, kind request to please
पूजा
mute
जी
yourself.
आपका खुला हुआ है mic. Dr. Moinak, Pooja Yadav is there. Her mic is open, so maybe she can be muted.
I'll just mute everyone. Second. Okay, I think
Okay,
she's
thank you
muted.
so much. Thank you.
Thank you.
So am I audible?
Sorry, Richa, please carry on.
Yeah, ma'am, I'm just continuing. I'm moving the slides. It's not, let me just start the share. Just a second, I'll start sharing again. And I'm unable to move the slides actually. That's what is. Okay. Sorry. So let's look at the mortality trend. So if you look at this graph, what we see very, very broadly. So the blue part is the under 5 mortality. That is 5 साल तक के बच्चों में कितनों बच्चों में मृत्यु हो रही है. So that's the mortality trend that this chart is showing, is from 1990 to 2016. Why we are saying 1990? Because around 1988, this entire concept of health for all came. So the baseline has been set at 1990, and from there onwards, taking the Millennium Development Goals and now the Sustainable Development Goals. So we are looking at the progression from that cutoff, that is 1990. So if we look at 1990, our under 5 mortality rate, and this I'm talking in context of India, 100 was 119. Our infant mortality rate was around 90, and our neonatal mortality rate was around 53. We were still not talking that time about the early neonatal mortality rates. Now, not going too much into the details, we can see a declining trend across. But where it gets a little bit choppy, I would say, is the period around 2010 to 2016, where if you look at the neonatal mortality rate, the decrease is slightly lesser than what we see across under 5 mortality rate or the infant mortality rate. But of course, the gains have been huge. I mean, if you look at the under 5 mortality rate from 119, we have come down to 40. So almost, I think, 2/3 reduction is there. Now, what is it that the neonatal mortality trends are showing us? Between 1990 and 2017, the child mortality came down by 70% and neonatal deaths by 55%. As a result, because the decline in neonatal deaths was much less than the child mortality or the IMR that we are talking about, the contribution of neonatal mortality to child mortality increased almost by 20%. So when I say 41% to 61%, almost by 20% point, the neonatal mortality contribution increased. And the contribution and this is the current status, the contribution of neonatal deaths to infants deaths, मतलब एक साल में जितने बच्चे मर रहे हैं उसमें से जितने बच्चे पहले महीने में मरते हैं, that is almost 70%, if 69 to 70%. And ये जो deaths हो रही हैं इसमें भी, as Professor Dhiman was saying, the first day is most crucial. 53% deaths हमारी first day में हो रही हैं. So that means early neonatal deaths is forming the bulk of all the mortality that is happening in under 5s. So ये तो हमें पता चल गया कि neonatal mortality is a very, very important issue that needs to be tackled. Now let's look at the causes, and this is something very interesting. I think something new that I learned over a period of time. Like if you look at the causes, we've all learned as part of our medical science that birth asphyxia, sepsis, and preterm or prematurity are the most common causes of neonatal mortality. But what is interesting, if you look at the bottom graph, what this graph essentially shows is that in 2010, and if I go back to this previous slide, the maximum reduction happened between 2010 and 2016. So what happened between 2010 to 2016? The Global Neonatal Action Plan came into force. So as a result of which, the country started a lot of action in and around at the facility level for tackling the death that was happening in the initial first day and the first hour. So what we see here is the death due to asphyxia and deaths due to septicemia coming down drastically. So अगर हम 2000 से 2015 में देखें, so there has been a drastic reduction. But what is it that has not changed? This is the prematurity or the low birth weight. Rather, its share has increased almost by 15% point during the same course of time. So there is something that we have been able to reduce, but there is something that we have not been able to address. And this is basically the advocacy statement that we need to chip in, that why maternal nutrition becomes very, very important. And this is the most recent data that came out in Lancet, that is, and for public health and nutrition, I think this is our Bible that we quote everywhere. So Lancet 2020 came up with really revealing data with regards to India, and this is specific to India. For neonatal deaths, child and maternal malnutrition was the predominant risk factor in almost 83% cases. जिसमें भी डेथ्स हो रही हैं 1 महीने के बच्चों में, उसमें बच्चे की malnutrition या फिर माँ का malnutrition is the most important risk factor. And almost जितनी भी deaths हो रही थी, almost 83% again were due to low birth weight or the short gestation. So या तो preterm थी या हमारा बच्चा low birth weight था. So this speaks volumes about where we really need to invest now that we have got those gains in the mortality. So now लो बर्थ वेट पे अगर हम आते हैं, सो ग्लोबली ऑलमोस्ट, ग्लोबली क्या, हम इंडिया की बात कर रहे हैं, तो हम हमारे ऑलमोस्ट 7.5 मिलियन, दैट इज 75 lakh kids are born every year as low birth weight kids. In specifically in UP, we are talking about almost 1.3 million, or almost 13 lakh kids being low birth weight. Now this is a huge number. 13 lakh cases, newborns out of 60 lakhs who are born every year are low birth weight. Now let's look at another implication of maternal nutrition. Now, if you look at this, this is a slide that which is very again specific to India. What does this show? This shows the wasting levels in newborns at the time of birth. And India is unique in the sense that in India, wasting levels are very high during the initial 6 months, which is in contrast to other countries like South Africa and all, where wasting levels peak only after 6 months are passed. So high wasting levels at the time of birth are again indicative of either the IUGR or SGA or low birth weight. So this is a very important implication in terms of how does it impact the maternal nutrition impacts the undernutrition status of a child. So these are the three key facts related to that. And now I think these are the common causes. I think we know what leads to low birth weight. And I would just focus on the bottom box, which talks about like what are the common causes in a country like India. And it runs across the cycle. It starts from preconception. It continues during pregnancy, and of course, it also happens during the adolescent period. So this becomes the main area where, or the main life cycle approach that we need to target. And in contrast, in the developing countries or जो developed regions हैं, there I think the multiparity, women are conceiving much later, around 35, 38. So multiparity becomes a very important issue there. So I think those are the other causes there. But in India, it's basically adolescent preconception and pregnancy care, which really matters a huge deal. And what are the predictors now coming? So we know that maternal nutrition is responsible in some way to birth outcomes. Birth outcomes can be low birth weight or the neonatal mortality, and which is we know the numbers are not improving, rather they are increasing in some way. And we have been able to bring down the infant mortality rates, but we have not been able to address the neonatal mortality. And somewhere the maternal nutrition is a culprit. So let's look at what are the factors that affect the poor maternal nutrition. We know behaviors. Dr. Piali was talking about the demand generation component. So that's a very important issue. मुझे पता क्या है, मुझे क्या खाना है, क्या नहीं खाना है, वो तो फिर भी बात की बात है. मेरा बिहेवियर क्या है? Is maternal nutrition even important? अगर आप गांव में जाएं, वहां पे बात करें, तो pregnancy is not an event also. It's just a routine thing. There's no need to even go and show yourself to a doctor. So how do you change that behavior? Food environment. क्या नहीं खाना है, इसको कम खाना है, ज्यादा खाओगे तो बच्चा बड़ा होगा. How do you influence that food environment? Then the entire health and nutrition systems. How are we reaching out to our pregnant women or to our adolescent or to the the eligible couples, the age between 20 to 24 when you are thinking of conceiving? So how are systems reaching out to them? Then the entire social protection. Abhi I'm not sure hospital facility में इतना नहीं ये चीजें इफेक्ट करती हैं, but if you go to a village, आपके पास पैसे हैं कि नहीं है, if that lady is working under some scheme, then is she getting her money or not? If she is not getting her money, then she continues to work till late in the pregnancy. So that affects the fetal outcome. So that is a very important factor. Then wash, hygiene, sanitation. I mean, without doubt, it affects the entire life cycle approach. And then the entire element of education. If you are educated, you will get delayed. Your marriage would be delayed, marriage is delayed, then the kids would be born late, and then the spacing would be proper. So everything is interlinked. But because of the paucity of time, I'll just quickly focus on the health and the nutrition systems that affect the maternal nutrition. Now, there are three key maternal nutrition factors which impact birth outcome. One is the poor maternal nutrition before conception. So before even maybe the adolescent phase or the period before which the mother conceived. So that has a very important role. Short stature. In India, I think somewhere along the line, stunting in the women is a very major issue. 145 centimeters से कम अगर height है, तो it's a high risk pregnancy. So that's another problem. Then another issue is that poor nutrition during pregnancy. Of course, family planning and wo sare bhi hain, but poor nutrition once she conceives, then what kind of nutrition is she getting? It's a huge challenging area, because if I recall the first presentation, we were talking a lot about different kind of micronutrients and macronutrients which affect the fetal growth environment. But is the child even getting 1% of it? That's the big question mark. Because if we look, I think still people who are accessing medical care are only accessing it at the time of delivery. What happens in the 9 months period? She's not getting any micro or macronutrients. So that's the reason for such poor birth outcomes. Now we know what impacts what. So this is again taken from a WHO source, that low maternal BMI in early pregnancy puts infants at higher risk of small for gestation age. So you will have smaller infants. Maternal anemia, we know prematurity and low birth weight cause karte hain. And if the maternal and iron itself is a limiting micronutrient. So if a newborn is born with low iron levels, then the possibility of him being anemic at 6 months becomes very, very high if he or she is not given the breast milk properly. So that is another big area of concern. Maternal short stature, we know it leads to delivery complications, cesarean delivery, pregnancy-related mortality and morbidity. Then the entire workload in rural settings, if we go, still women are working. Yes, physical exercise and physical activity is very, very important, but too much of work or too much of stress that is often we see in rural areas, I think that is also detrimental factor, especially so if the mother is already underweight or undernourished. And this is an interesting thing that I found in one of the, and I was not really aware about it, in one of the resource literature, that undernutrition in first trimester leads to small infants. Undernutrition in second trimester results in infants that are both small and thin. So जो हमारे जो actually SGA babies हैं, ये हमारे second trimester में, if we don't, and I think somewhere along the line this is related to the kind of nutrition requirement also, which increases as the pregnancy progresses. So it's just like, it's just 1 to 2 kg in the initial first trimester, then 2 to 3 kgs, and then the final 5 kgs in the last trimester. That's the weight gain that is expected. And the later gestation, if or undernutrition continues to be poor, then the small head circumference. So it's basically first trimester में भी अगर हम control कर लेते हैं, तो we can still address the risk that we are exposing the newborn to. But if we don't control it in the first trimester, then second and third trimester are completely, like the baby is really, really at risk. And that is what the government scheme says right now. It's like mandatory early registration of pregnancy. अब अगर हम गांव में जाते हैं तो early registration तो होता ही 2.5 महीने पे है, या बहुत अगर active, that too if the mahila is really, really active and proactive about her health, then she would go out to a health center and register herself. Otherwise, most of the cases what we see is the first trimester is gone. You have already left exposed the child to being malnourished, even if the mother is healthy. So that's the big risk factor. So I think we really need to target in the first trimester. That is really, really important. And then we know what works. I think Dr. Verma was also talking about it. Balanced energy and protein supplementation. 20% आपके खाने में कम से कम प्रोटीन होना चाहिए, जो आपको रेगुलरली डेली डोज में लेना है. Iron, folic and calcium supplementation. Deworming, I mean, if the government की policies हैं, तब आप deworming भी महिला को दे सकते हैं. In India, it's being given. Weight gain monitoring, very, very important issue, because you cannot take a BMI if the mother is pregnant. BMI is valid only and only in the first trimester, if at all. Otherwise, BMI becomes irrelevant during pregnancy. So weight gain monitoring becomes very, very important. Then the entire counseling aspects. Do we know even how to counsel? I think that's the question that I kind of ask every time when we talk about this kind of a statement. Who is a good counselor? Have we even taught them the good counseling skills? And last but not the least, where malaria and anemia are a common thing, then we need to address this. This is something that has been prescribed by WHO. Now, and of course, then this जैसे बच्चे के लिए diet is important. It's the quality of the diet. It's the diverse diet. So So first trimester में the mother has to have 3 meals plus a small meal. In the second trimester, 3 meals plus 2 small meals. This needs to continue in the third trimester also. And plus the variety needs to start increasing. And more so, not only during pregnancy, even during the lactation period, the mother needs to consume. And what she needs to consume amongst the array of things that are available. उसको अनाज भी खाना है, उसको हरी सब्जियां भी खानी है, उसको विटामिन ए रिच फ्रूट्स वेजिटेबल्स भी खानी है, उसको नॉनवेज भी अगर फैमिली में खाया जाता है तो वो खाना है, पनीर लेना है, दूध लेना है. दिस इज इन द आइडियल वर्ल्ड, दिस इज व्हाट शी इज सपोज्ड टू ईट. एंड ऑब्वियसली आई थिंक बिकॉज ऑफ द इन्फ्लेशन या जो भी है महंगाई, हमारा कंजम्पशन इन सब चीज़ों का बहुत कम हो गया है. So our diets are becoming very, very heavy or rich in cereals, but they are really, really short of, like, the vegetables, the proteins, the green leafy vegetables or the vitamin A rich vegetables. So that is actually impacting upon the nutritional status of the mother. So these are the things that are recommended, and I'm just talking about the recommended, but the reality in field is completely different. Then the supplementation. The Government of India guidelines says that दूसरे ट्राइमेस्टर से जैसे ही महिला चाहे चौथे महीने में जाए, उसको आप आयरन की टैबलेट देना शुरू कर दीजिए. अगर अनीमिक है तो 2 टैबलेट, अनीमिक नहीं है तो आप उसको 1 टैबलेट दीजिए फॉर नेक्स्ट 6 months. नाउ 180 टैबलेट्स इज व्हाट शी इज सपोज्ड टू गेट. 6 months कंटिन्यूअसली, 1 टैबलेट एवरी डे. कैल्शियम में उसको 2 टैबलेट्स लेनी है, starting from second trimester onwards, again 6 months postpartum. So this is the calcium recommendation. Albendazole again second trimester में उसको 1 बार during pregnancy लेनी है. Now the challenge, practical reality. We tell her to eat 2 tablets of calcium and 1 tablet of iron. Assuming she has no problem, no anemia. 50% में तो anemia है. Now 2 tablets when she has to consume, she has to space them at least an interval of 4 hours between iron and calcium. तो हम ये कहते हैं उससे कि भैया दोपहर के खाने के बाद एक कैल्शियम लो, रात के खाने के बाद एक कैल्शियम लो. So when will she take iron? Then we tell her, okay, या तो शाम के नाश्ते में आप आयरन ले लो या सुबह कुछ खाने के बाद ले लो. Now in rural settings, people don't eat so many times. एक बार खाना बनता है, that is consumed throughout the day. So the challenge is that how do we improve this entire supplementation? The reporting is around 80%, but actually in reality, the coverage comes to around just 12 to 15% is what the women are consuming 100 tablets. I'm not even talking about 180 tablets. Then the entire antenatal checkup. So we have talked about diets, I've talked about the supplementation, and then the entire weight gain, this distribution, and going for regular health checkup and examination. And if there is any risk, then please get admitted to a health facility. And then let's look at how we are programming. In India, we are performing the best in terms of our policies. We have this is India, and we are green in everything. We have an iron folic supplementation program. We have a calcium supplementation. You name it, and we are there. We are giving poshahar to these pregnant women. We are assessing anemia. Hemoglobin checkup होता है. हम counseling सब चीजों में कर रहे हैं. So we are talking about protein intake. We are talking about micronutrients. We are talking about भैया खाना है आपको. So we are pretty green in everything in terms of our policies. And it's not that everything is not good. We have if you look at the yellow and the blue bar, basically it shows how much progress we have been made. So even if I don't go into the individual bars, basically what we see is that there is an improvement in over a decade since the National Health Mission has come. And that's the mission that addresses all the public health programs around health and nutrition. We do see a lot of improvement in terms of the major factors that we're talking about for improving maternal health and nutrition. But still we are not doing good. Look at the status of states in India in terms of BMI. हमारी अभी भी 1/4 of the women in reproductive age group are 1/4, 25% have a BMI less than 18.5. तो हमने 25% बच्चों को तो within womb भी हमने उनको malnourished कर दिया है. So this is a big problem. Now by 2030, I think what we have started talking about now is that obesity is also gradually increasing. Still, we are in a happy space in UP, but I think if you look at the rest of India, obesity, especially the well-to-do states, obesity is gradually increasing. Then again, anemia, I don't think so. We look at the last 3 bars, no change in 10 years. So that means hamara iron program is just not delivering. Nobody is eating the iron that we are giving. So there's something that we drastically needs to do in order to improve this, the anemia challenge. BMI has kind of come down, so there's a slight improvement there. So, and most of the Indian women enter pregnancy with poor nutrition status. So, if you look at 15 to 19 years, BMI is less than 40%. Girls have a BMI less than 18.5. Reproductive age group, मतलब 20 से 24 साल में 23% have a BMI less than 18.5. So, with this scenario, I mean, how do we really, how are we going to address neonatal mortality is the big question mark. And UP, I think we are not really doing great, but anyways, I'm not going too much into the details. Maternal mortality, I think we have done wonders because of the institutional delivery. The maternal mortality has improved considerably. The neonatal mortality still continues to be very, very high. And you might have seen the newspaper, the Times of India today, which says that हमारे यूपी में deaths होती हैं out of 2.5 लाख infant deaths जो हो रही हैं. तो neonatal mortality continues to take toll of the kids born in UP. And that's the scenario. I'm not going too much. I mean, we can share the presentation. Full ANC care. Full ANC care means 4 एंटीनेटल चेकअप्स हुए हैं, सारी टिटनेस डोजेस मिल गई, आयरन कैल्शियम सब कुछ मिल गया, only 6%. So you can see the challenges, and when it comes to the public health care delivery system, decision making. I mean, only 10% women are participating in some kind of a decision making. We are talking about a flagship program of Mission Shakti. We really need to empower our women to at least take decisions with regards to their own health. 90% हमारी महिलाएं कुछ सोच ही नहीं पा रही अपनी health के बारे में. It's the others who are deciding for them. Uh, Secondary or higher education, I think a lot of school dropouts are still happening. So there are very few women who are even completing the higher education. So that's the huge challenge. And this is something I would really like to draw the attention. I don't think so you would have seen it in the facility care, but this is a huge 40 pages maternal and child card that is provided in rural India across PAN states. So across India, this is the endorsed card. And if you look at the quality of feeding, I mean, this is something that as UNICEF we are taking up gradually with the government, is that this is the details that is supposed to be entered month after month. So ये जो 9 आप देख रहे हैं columns, this is the 9 months of pregnancy. When she goes for her checkup, if not 9 times, at least 4 बार तो कुछ entries होनी चाहिए. So this slide is just to show that how much we are missing. There is no information. So if there is no information, then what are we really addressing? और जहां इंफॉर्मेशन है वो गलत है. कई जगह जहां पे अगर आप देखें नो अनीमिया, ये अनीमिया का कॉलम है, नो अनीमिया, नीचे अगर आप देखेंगे हीमोग्लोबिन 9.8 ग्राम. सो either we are not serious or we don't know, and I think the answer is that we don't know. हमारे health workers को भी reaching them with so much of information or teaching them to take this issue seriously is a challenge. And again, the same thing. If you look, this lady, I think she was supposed to get 4 checkups, only 2 details हैं. ऊपर वाले columns which talks about the high risk pregnancy, these are never filled also. So that's where we are. And what next? I think it's just like, our current focus in terms of our programs, because this is where we are currently focusing, this entire circle. And this is tilting the balance. The balance is completely in favor of those 2 days when the woman is coming for the delivery. What is happening during the 9 months? I think a lot needs to be done there. And the top priorities, I think universal coverage. There is something known as a VHND day, Village Health and Nutrition Day, where there is an auxiliary nurse midwife who goes and gives services in the rural areas once a month. So these really need to be prioritized. Again, the supply side, we have gaps in terms of the human resource, the logistics are not adequate, the kind of hemoglobinometers which should be there, or the weighing scale should be there. Of course, 80% they are there, 20% there's still a gap. And then the entire component of quality care. I'll not go into the details, but yeah, I mean the quality of care, the purpose of showing those cards was that the quality of care is severely compromised. We are just giving 2 shots of tetanus, and that is the end of, and distributing some 20-30 iron tablets, and that's the end of the maternal nutrition, maternal health journey for the 9 months. And demand generation, I think that the need is to start talking to these. There's a huge group of women who are known as self-help groups. They're empowered women. We need to, like, get in touch. And there has to be this private public connection somewhere, like, where the doctors, the nurses, they can go down, and even if, like, once a visit, once a month, to one facility or one village would make that kind of a difference. So I think that is one of the key suggestions. And then, of course, like, looking at the quality of reporting and the third party validation. So that's about my presentation broadly. I mean, like, and that's the last slide. So thank you so much for listening. And that's
Thank you, Richa ma'am. That was a very, very useful presentation, no doubt. And I've been making some notes and planning to ask a few questions if you don't mind.
Yeah.
Ma'am, इंडिया हम लोगों का हमेशा एक we've always been crying somehow. हमेशा हाय तौबा, हमेशा we are all chest beating, हमारे statistics ठीक नहीं है, and infant mortality rate ज़्यादा है, maternal mortality rate ज़्यादा है. On one hand, and I see a little bit of paradox. On one hand, madam, we are saying our women have improved antenatal visits. We are saying that they are a little better educated as compared to what they were earlier. आंगनवाड़ी में खिलाते हैं, फैमिली प्लानिंग इम्प्रूव हो गया है, हमारे women स्मोक नहीं करते हैं, बट फिर भी मैडम 83% of our burden which Lancet you have just quoted is linked to malnutrition. Where are things going wrong? If you can highlight one important factor, and is it that we are hiding the reality? Because you're from UNICEF, you're going to be impartial in your analysis. And can everything be zeroed down to poverty and GDP then?
Okay. Absolutely no. I think where we are going wrong, what you have pointed out, absolutely, Dr. Moinak, is that the recognition of malnutrition as a problem is not there. If you really see, I don't know, you might have heard a lot of debate about Global Hunger Index that was done in 2019 and again this year. So 2019, I think we kind of deteriorated on that index, and there was a lot of hue and cry. And then there was an alternative, analysis that was done to show improvement in the global hunger index. So basically, malnutrition falls between the cracks. It's and the way our policymakers look at malnutrition, it's largely from food perspective. खाना दे दो ठीक हो जाएगा. Problem सारा का सारा वहाँ है. It's not the food which matters. And if you look at, because I work with the health sector also, the challenge that I foresee there, the burden of tackling mortality itself is so huge that going into the preventive care requires another set of workers completely.
So you are saying, ma'am, manpower is a problem?
Priority is a problem. Recognition of the issue is a problem. Prioritizing that issue within the sector which has good infrastructure, that is health, is a problem. ICDS is a food distributing engine. That is how we, like, we don't even bother ki growth monitoring ho rahi hai us aanganwadi pe ki nahi. So I feel that prioritization of malnutrition is a huge problem. We have a Poshan Abhiyan under the Prime Minister, but kitna review hua hai? How have states really improved? Is there an independent survey that has happened? How are we? It's all about data. So I
Can
think
you come to one single most important factor out
priority.
of all this?
Priority.
So you're
Priority.
saying the people at the top are not prioritizing malnutrition
No.
the way it should be.
Yes.
Ma'am, that comes to my second question. हम लोग जब इंडिसेस दिखाते हैं इंडिया का, हम लोग साउथ एशिया में बेस्ट कहते हैं मैडम खुद को. हम लोग अंधों में काना राजा है क्या? In the sense that we are not, I don't want to be really compared to Pakistan, Bangladesh, and Afghanistan and call myself a king. I'd rather be compared to Thailand and Malaysia and see really, are we doing as well as they are?
Okay.
So
Okay.
why are we being heroic by saying that India is the best amongst South Asia? Because just because
Okay,
we are
that okay. So that slide, if you put that slide even on a global platform, we would still be the best in terms of our policies, because
but
you
still,
need.
ma'am, Lancet makes us 83%.
Yeah, so Lancet, because Lancet has been focusing a lot on India. If you really see, there's a 100 million deaths study in Lancet dated, I think, 2017,
Yeah.
which is actually this prematurity thing has come up from there only, that it's not improving. So I think somewhere along the line they are pushing.
And Lancet, ma'am, we worked with you on severe acute malnutrition a few months back.
Mhm.
Piali, Dr.
Yeah,
Piali,
yeah, yeah.
myself, and you. And you would remember the Lancet statistics at that point of time also, we were targeted and we were called the worst amongst the malnourished,
Yeah,
less than 5.
yeah.
So, kahi na kahi to ma'am gap hai, which we are not either addressing or we are hiding. Yeah, we are underreporting. I'm not sure.
It's a combination of all three, because
Exactly.
see, to a policy maker to explain them what is the difference between stunting and wasting is also a challenge. I mean, 6 years back when we started working on this nutrition mission, I used to get calls like, I mean, why are you complicating things? Why can't you just talk about
Hmm.
underweight? So, we cannot simplify nutrition even if they want. It
Yep.
is a complex issue. And the problem is that that complexity can be addressed only if you have the intent. What I feel missing, I mean, it's a day-to-day struggle going in the health, like, talking about maternal nutrition. Are richa ji chhod dijiye, abhi pehle to hum yahi kar lein. So it's all about, like, facility certification, facility
So,
accreditation.
apathy, an
Yeah,
element of
complete
apathy.
apathy to the challenge. Wasting, matlab, it's just
Can I
restricted
make a
to us.
comment, please?
Yes, yes,
Yeah,
yes,
please,
ma'am.
See, I wouldn't say it's apathy, but Moinak, you will have to understand that we have to prioritize so many things at one point of time, and it is the same health worker who is
yeah.
dealing with
Yeah.
all these programs, so he's overburdened, he or she, and एक से दूसरे में jump करेगा. The person who's looking after the polio program will be looking after the maternal nutrition, will be also looking after the daily iron program, will be looking after the sort of filaria control program. So they are so overburdened. We are actually, Richa is correct, we don't know when and what to prioritize. So
So
maybe
priority and
we can,
manpower.
yes, there's a question of manpower over there.
Hmm.
मैम एक पियाली मैम एक छोटा सा सवाल आपके लिए एंड I practiced in as a faculty in Nepal much before I came to SGPGI. And a very funny incident happened. I was taking rounds in the neonatal ward, and there was a baby with a grandmother. And every day I used to ask the grandmother, "Is the child feeding?" And she would say yes. "Is the child feeding?" And she would say yes. On the seventh day, I asked the grandmother, I said, "Where is the mother? I never see her." Then the grandmother said, "Oh, she's gone on day 2. She's gone home. The child is now with me." So then I was amazed and I said, "What are you feeding then?" Then, all the ladies, all the other mothers in the ward huddled together and said, "We are feeding that baby turn by turn every time." So the baby has a kind of a cafeteria approach or a buffet breastfeeding, whatever you would like to call it. But that brought a very important concept. And you see, in Nepal, madam, the primary problem is always linked to unavailability of health centers, which we can't actually complain about. So what the women do is they get united and they try and salvage their babies this way, like the way I'm saying. So if the mother is not around, other mothers tend to pool and help themselves.
The self-help groups, as we call them.
Self-help group. So the women have empowered themselves that way. Their statistics are very poor, no doubt. We are not going to go into that. But ma'am, going by that, is there any role for our mothers to self-help themselves? Is there any way can we empower our newborn statistics and maternal mortality statistics.
Definitely, you are very correct, Moina. Uh, if these mothers can be educated to, there are many of them who are throwing away milk,
Yes.
and our breast milk bank is at dearth because we don't have sufficient amount of mothers. So if we can counsel and educate these mothers to donate, that would help many a child, because our NICUs are full, NICUs are full. We have so many children there who would want but cannot have mother's breast milk because the mother is either poorly nourished or sick or unable to give. So these children would really benefit from the breast milk bank from any other mother. And I don't know what has happened to us down these centuries, because we had the concept of actually a sort of a pannadai in our society, where the other mothers used to feed simultaneously some other lady's child along with her own child if in need. But up though, I don't know, we have changed our entire outlook of thought, and we say, why should we give it to somebody else?
मैडम खून
So,
रिश्तेदार तो खून नहीं देते हैं, ऑर्गन डोनेशन तो बहुत दूर की बात है, ब्रेस्ट मिल्क कैसे देंगे लोग? सो दैट मींस कहीं ना कहीं हमारा, आर वी नॉट एजुकेटिंग द masses on this?
yes, I think we need more of awareness, and possibly that is why we are holding these days and weeks and trying at our best. But the educative level, I don't know what the person thinks or is extremely selfish nowadays. Think denge lekin denge nahi. That is the general attitude. Maybe we need to concentrate more on the mothers, and we have to have self-help groups, as you say, where one mother educates the other mother that you can do such things. Maybe huddling these mothers together will help a little.
Absolutely. अच्छा, सेल्फिश से मैम डॉक्टर शिल्पा, मेरे पास एक सवाल है. शिल्पा मैडम इज अराउंड? शिल्पा
No,
मैम?
she's not.
Shilpa ji, I can
She's
see
there.
her, but I don't know if she's available.
ओके ओके मैम, सेल्फिश से एक बात ये आ रहा है मैम कि mother is selfless when it comes to giving iron to her child. I mean, there was a time, ma'am, when we used to say mother can be anemic, but baby will never be anemic. Now we know that that concept is not so valid, because the children have these anemic mothers give rise to babies who have poor iron stores. But what is it about the maternal-fetal exchange, the iron handling, that the mother becomes selfless while giving her iron to the baby? And that makes, as Richa ma'am had pointed out, 50% of mothers at any point of time at any age are anemic. And anemia has become one of the topmost concerns of our government programs these days. So what is it about the placenta, madam, that allows this to happen?
See, as you said, selfless mothers, definitely. Mothers are transmitting through the placenta not only iron, but lot many things, including vitamins, minerals, a lot of other things as well. So, selfless mother, yes, माही दुनिया में एक ऐसी लेडी होती है जो अपने शरीर को काट के देती है.
Yes.
So she is giving. But remember that a mother, if not given proper nutrition, as Richa was saying, she is herself deficient. So now that we know that she will give rise to a preterm child, a child who is easily amenable to infection, and this now becomes a epigenetic effect, sort of an intergenerational effect, giving rise, this baby who grows up will become a mother, again will give rise to a weak child, and this generation will become weaker and weaker gradually. So we did start so many programs, including the iron program, WIFS program, which we were giving to the children at school. But as Richa says, we don't seem to have been doing a great job of it.
Impact. Yes, absolutely.
And just to add and share, like, the government has been running this, now it's an entire part is now known as Anemia Mukt Bharat. So all the stakeholders have now come under, not the stakeholders, sorry, the adolescent, the pregnant, the kids, the lactating women, all are part of now Anemia Mukt Bharat. For kids, there is a separate, like, the government is providing these IFS syrup, which is 50 ml. So 1 ml per day for 6 months. So 48 doses twice a week. And then again, for next 6 months, he or she is supposed to get another 50 ml of syrup. The challenge in our system is that they don't understand the importance. So again, the syrup is not given to the kid. It's rather given to the mother without even understanding what's the use of this syrup. So, it's like we are unable. So as ma'am was saying, one is the overburdened functionaries. I think overburdened systems in terms of programming. So for every, I remember as a medical student, or rather when I was doing my MBBS, I think that time it was like there's this program CSSM, Child Survival Safe Motherhood Program. Very simple. You consider them as a mother-child diet. 5 intervention karo, अच्छे से karo, they will be safe. And there was nothing that was different then than what is different today. The big change that has come is that there are 150 programs which are independently getting executed. So there is a WIPS, there is a IFS syrup, there is a breastfeeding, there's a complementary feeding, there's an SNCU, there is an NBSU, there is an NBCC. We just don't know how to, like, merge them together. And I think, I don't know whether it will really happen in reality, but what I hear now is that they are coming back to the concept of primary health care. So this entire concept of Ayushman Bharat and primary health care may replace all these programs eventually, because I think it's too big an elephant to manage now.
Handle. Yes, they have actually started giving deworming along with the iron tablets now. And I believe they will actually combine many, many more things together, along with the midday meal and everything that we are offering to the children.
Can we have some questions from the uh, others who are joined with us? Maybe the dietitians, our
So, Rama, Mridul, anybody who has a question?
anybody?
I
मैम
think
एक ये बड़ा मतलब स्टूपिड सा सवाल है, लेकिन परसों नहीं पिछले हफ्ते हमने एक बच्चा देखा था मैडम, न्यूनेटल कोलेस्टेसिस का, चाइल्ड विद जॉन्डिस, एंड द फादर सेज क्योंकि हमने माँ को हल्दी खिलाया प्रेगनेंसी में, तो इसीलिए बच्चे को पीलिया हो गया. अब ऐसे इट साउंड्स फनी, बट ऐसे कॉन्सेप्ट्स को कैसे डिसॉल्व करें? एंड ये सिर्फ इसके प्रॉब्लम नहीं है, द नेक्स्ट चाइल्ड दैट इज गोइंग टू बी बोर्न आल्सो, he will do the same thing, that he will say the mother have plain food, don't have with healthy, because the child will have philia.
so. I think there are a lot of myth bustering to be done as well.
Absolutely.
So there's so much of myth in the community about food that you need to actually do a lot of myth busters. But what I tell these people actually is खुदा पे खुदगारी नहीं होती है. Don't try to manufacture things for them. What is naturally coming in diet, please allow that. You have a staple diet, continue with that instead of trying to do खुदा पे खुदगारी, trying to do what is very best. Like रोज तुम अगर उसको आंवला खिलाओगे या रोज सेब खिलाओगे तो वो तो खाएगी ही नहीं, चौथे दिन बोलेगी मेरे को उल्टी आती है इसको देखने से. So you can give her choice, but try and give the staple food which normally that the mother has. कईयों को आई हैव सीन दे विल आटे को घी में मार के उसके बाद उसके ऊपर घी चुपड़ के पराठा खिलाते हैं. Now a woman who has never had this in her life, she will vomit with all these things. So over is also bad and undernutrition is also bad. I've seen the other spectrum जहाँ arrowroot घोल करके बच्चे को बोतल से पिलाया जा रहा है. The older child is feeding the child with a bottle which has arrowroot ghol because there is no milk and the mother has gone to work. So we have two big spectrums where we have overfeeding, we have underfeeding as well. Associated with it is शहद चखा दो, प्रीलैक्टियल फीड्स दे दो, जन्म घुट्टी दे दो. Every third child, this is 2020, every third mother will ask me, मैडम शहद चखा दे, जन्म घुट्टी तो नहीं पिलानी है. So I don't know, I think we are कहीं पे हम लोग चूक रहे हैं. We are not giving preconception counseling. Maybe that would help.
Yes, ma'am. Actually, that is also coming up as a big area, but the problem is that we don't have platforms to catch hold
Address
of them.
them.
Like, जब प्रेगनेंसी होती है तब हमारा एक VHND होगा या हॉस्पिटल में जाके दिखा लेंगे. So वो, I think the challenge is when to and where to catch them. The second I also feel is that communication has boiled down now to simple IC. कितना छाप सकते हो, कितने आप नई चीजें, I mean, those are really not needed. What we need is our people to talk. And I think
Are these concepts, ma'am, the way you are saying, ma'am, you said wonderful facts, and you said 1/5 of UP is still wasted. The newborns
yeah,
are born wasted. 13 lakhs out of 60 lakh babies that are born are in a wasted stage. Now, these programs that you are talking about, these concepts that you're talking about, why they can't be incorporated in our class 10-12 syllabus? The what you're talking, is there a role there to play
uh,
regarding, so
of
that,
course there's
because
a role. There is a role, but what I feel, Dr. Moinak, is like, because I've done it from community medicine, and looking at that learning that I have, I think it's very important, because I think the clinical people consider public health as a very, like, non-entity kind of a thing. So it's like, if you, I think that kind of a mindset is still there, that, like, ये तो low rank वाला subject है, इसमें जरूरत नहीं है. I mean, that's what I feel even when I interact with many of the government people also, like, क्या आप लोग nutrition की बात करते रहते हैं. So I think, of course, syllabus is very, very important, but the syllabus has to link it to the program understanding. What I often feel when I interact with people is that the problem and the program linkage is missing. So we are running the programs without linking it to actual scope of the scale of the problem. So हमारे पास एक NRC है, we are happy that NRC is tackling wasted kids, but that's tackling just 18,000 out of 1.5 lakh kids who are wasted in UP. So we are happy with that 18,000. We don't want to look into the other components. So
When I'm talking about education system, if I tell you the truth, I talk to the kids every day. We show them the food pyramid. We tell them about balanced diet in our education program. बट द प्रॉब्लम इज व्हेन आई आस्क देम कि आपकी थाली में आपने देखा कि ये चीजें हैं कि नहीं है, they have not even translated it to their own thali or their own plate. So what they are having is not what they are learning as balanced food. So that translation or that connect between the mind and what actually is being done, if we can promote that somehow, this is going to help.
नहीं मैम, जो हमारा बेसिक, हम लोग क्या, हम लोग अब गांव गांव जाके काउंसलिंग तो हो नहीं पा रहा है. तो अगर ये सिलेबस में आ जाए, क्योंकि यही लड़के जो गलत खाना अपनी बीवियों को खिलाते हैं, यही बीवियां जो है आगे जाके they remain malnourished, anemic, they give rise to anemic children and malnourished babies. Somewhere this chain, maybe, I'm not an expert in this field, but somewhere this chain may be
You didn't
broken.
assimilate what I said. It is in the syllabus, but not being assimilated in thought. Do you
Right.
understand that?
Yeah,
The
yeah.
teacher will just
Implementation
teach
नहीं है.
what is there in the book, but the practical application of that, translating into the child's own
Absolutely.
food habits, is not there. Just yesterday we had a session in which children were with me and I told them ki Cadbury jo aap itna khate ho, it was on junk food, and they said so many things about junk food. Ye hota hai junk food se, wo hota hai junk food. And then I said name a few and how many times do you have it. And though aap Cadbury khate ho, so I asked the mother, what do you gift him when he's done something good? She said, I give him a Cadbury. I said, do you know that that is a junk food? That has a lot of caffeine in it. So she didn't even know कि उसकी nutritive value है नहीं है, उसमें caffeine है नहीं है. So generally what we are doing, we are not translating into day-to-day life. We are learning, but that learning has actually no meaning in practical life. Syllabus में सब कुछ है, पर उसको translate तो करे जिंदगी में.
And ma'am, just to add here is also the fact that जो syllabus बना रहा है, who is very different from those who are actually, passing on the content to the kids. So, I
Exactly.
mean, if you look at the government, the way the system works, there is a separate department in education which is actually working on the syllabus of kids. We tried doing that as part of nutrition mission. I think we included the wash components, we included the programs. So भैया आपके घर के बगल में एक आंगनवाड़ी है, जाके यहाँ से ये चीज ले लिया करो, बच्चे का वजन कराओ. What happened 2 years down the line? The books got changed. So, you know, it's like the challenge is it doesn't stop at one place. ये कर दें तो शायद address हो जाए. It's huge.
Mainak, Dr. Shilpa is here, so if you can address
Yes.
her with your
Yes,
question
sir.
that you had.
No, I addressed that. I
To
asked
Richa
you
ji.
only. Yeah, I asked you and Richa ma'am the questions I had to have. I
So we
actually,
can call it a day now.
yeah, we can call it a day. We can call it a day.
So, Rama, can I please give a vote of thanks to everybody who's been behind the curtain and of course with us.
Sure,
So,
ma'am.
okay, so there are two people who have been a backbone to this whole program. One is Rama herself, who's our senior dietitian, and one more is Mridul Vibha, who's also her friend and a very dear friend to me also. She's also in the dietetics part. So these two have been a backbone to me in organizing this. So I thank you both. Thank you so much, Mridul and Rama. And I would like to thank two more people, Amna and Repudaman. Repudaman has taken care of the whole technical aspects from SGPGI. He has generated the Google Forms, the links and everything. So Ripu, a special thanks to you. And to everybody, I must say no program is complete without the participation of so many people. I believe, Rama, we had about 111 people who participated here and on YouTube. So I thank each and every one of you for suffering all of us throughout these 2 hours. Thank you so much. So good night, Shabak Khair.
night.
Have a very, very good day. Thank you so much.
Thank you.
Bye-bye.
Thank you.
Thank you, ma'am. Thank you, Dr. Moina. Thank you.
Shilpa ji, thank you so much
Thank
for
you,
coming
ma'am.
back.
And
I
sorry
believe,
for
is everything all right?
yeah, so far so good. He's
Good.
come COVID positive now. We are shifting him to a COVID facility. So
Okay.
let's see.
All
So,
the best.
sorry for whatever
Ha.
I had
We will
done.
keep you in our prayers. We'll keep you
Thank
in
you.
our prayers.
Thank
Thank
you
you
so
so
much.
much for still being with us. Thank you.
Thank you.
And